and work as a global medical affairs manager there. I am a graduate of the program here. It's been a while since I've been a student, but I'm just very proud of the program and very proud that we're doing this this conference here. So again, thank you and welcome everyone this morning. Again, I think this is going to be a really interesting topic we're talking about today. So I hope you guys find a lot of value in this. So let me go ahead and
Bill, somehow you got muted.
there we go. And you guys able to see my screen okay? Very good. Okay, excellent.
Yes.
Thank you. Thank you. So before I get started, I'd just like to say happy Respiratory Care Week next week to everyone. I want to thank all the respiratory therapists, respiratory professionals, just for the dedication that you provide to your patients day in and day out, and really everything you do for the profession. So again, thank you guys so much. And as a former bedside RT, I really, really appreciate everything that you guys do and where our profession is going. So again, thank you guys very much for that. And if we don't touch base next week, have a great respiratory care week. So let's get into our topic today. Ventilator-induced diaphragm dysfunction and how it perpetuates dependence on mechanical ventilation. It's a topic I find very interesting. Thinking back to when I was a bedside RT, all the different patients that could have developed VIDD or had the potential to develop VIDD. I think we think a lot about lung protective ventilation. It's been around for a number of years. We know how to approach it with the smaller tidal volumes, trying to minimize driving pressure and plateau pressures, minimize FiO2, but we also, I think, need to really be aware of the diaphragm, because as we'll see in a few slides here, it really plays a major part in our breathing and can really be impacted when we place patients on ventilators. So I think it's a great topic. I think it needs more awareness, and I think we'll start seeing even more clinical studies come from this topic as well too. There we go, it's better. All right, so what we're going to talk about today is we're going to go over a little bit of anatomy and physiology, just a high level overview. And it's really just to kind of set the stage of how important the diaphragm is when we're talking about breathing and how much it can be impacted on when we're placing someone on a ventilator. We'll then go through some history on clinical studies on the diaphragm and its impact from mechanical ventilation. We'll talk about some relevant statistics as well. Then we'll go into myotrauma, which is a really can be a really big factor predisposing patients to VIDD. Then we'll look at some diagnostic tools on how to evaluate the diaphragm and kind of monitor it during their time on the ventilator. And then we'll look at some additional risk factors or contributing factors to VIDD, such as sepsis and malnutrition. And then we'll end our discussion today with some mitigation strategies. How do we mitigate the potential for VIDD? All right, so we'll start off again, like I mentioned, with just a high-level overview of anatomy and physiology. And we know a few things. We know that breathing starts in the respiratory control centers, up in the medulla oblongata. It's the primary respiratory control center that really kind of gets the information from the body, processes that information, and going to send it out to the muscles of breathing. That also controls like the rhythmicity of respirations as well too. Within that medulla, we have those two regions, the dorsal respiratory group and the ventral respiratory group. And the DRG kind of receives those impulses, that information, and we'll see in a minute from the chemoreceptors within the body. The VRG kind of helps determine the rate, rhythmicity, and the depth of breathing. So really, this is where our breathing starts, right up on those respiratory centers. Now, the information that those respiratory centers are going to need to kind of process and determine how we need to breathe you'll see up in red there on the slide here, and it's really, again, as RTs and clinicians that manage patients on ventilators, we see this as very common because we see this on our arterial blood gases, right? So that information is collected by the chemoreceptors. They take that information, put it in a nice little package, and send it off to the respiratory control centers. Those respiratory control centers then process that information and determine how we need to breathe. So if it's a situation where maybe someone is in a really intense workout, we know this CO2 is climbing up a little bit, maybe a little bit of lactic acid buildup. Those respiratory centers are more than likely going to say, okay, we can't maintain that normal breathing. We need to breathe a little faster and deeper to help blow that down and kind of normalize that pH. On the other hand, if you're just sitting on the couch watching some TV, then the respiratory centers may say it's okay, this standard normal breathing, we don't need to make any changes. Whatever that situation may be, those respiratory centers are then going to send those kind of orders, that plan down to the muscles of breathing, which is going to be the diaphragm is going to be that major muscle. Once they get those little signals or get those orders, those muscles of breathing are going to start their process, and then ventilation occurs. So again, depending on what the situation is, whether you're working out or sitting at home or you're nervous or stressed, whatever that may be, those respiratory control centers are going to be the one that kind of helps determine what kind of breathing that you need to do. I'm going to send that down to the muscles of breathing to start that whole process. Now, if we look at the animation on the right here, this is kind of what I was just mentioning here, where we have the respiratory control centers up in the brain there, and we have the phrenic nerve in green there. So the signal is sent down the phrenic nerve to the diaphragm. Once that signal hits the diaphragm, it's going to get that diaphragm excited. It's going to contract and start pulling down, creating that negative pressure to allow air to flow into the lungs. So really, this is just kind of a representation of spontaneous breathing. But as we can see, the diaphragm plays a really large part in all this. Once they get that signal, that's going to be that major muscle that starts that process of breathing. So we mentioned the diaphragm, right? And a lot of the focus on this conversation today is about the diaphragm. And again, it is the major muscle of ventilation. And we know a few things about the diaphragm. It's dome-shaped, it has right and left hemidiaphragms. It's the partition between the thoracic and abdominal cavities, but it's only roughly 2 to 3 millimeters thick in healthy adults. So not a very large muscle, not very thin. So when we start getting into the conversation on VIDD, mild trauma, and some other factors that contribute to the potential of VIDD, just recall when we talk about the thickness of the diaphragm itself, because as we know, and we'll see here shortly, it can atrophy very quickly. It can, like any other muscle, if it works too hard and get thickened, which really can impact the ability of the diaphragm to function appropriately, especially when we want it to, when we're getting into that weaning phase of ventilation. So continuing on with that conversation, just in kind of highlighting the importance of the diaphragm here, just want to kind of go through the process of inhalation and exhalation, just again to really support that importance of the diaphragm. So when we get inhalation, we get that phrenic nerve signal come down, hit the diaphragm starts to contract. Rib cage expands, preparing for some volume. The lung volume gets ready to increase. Pressures in the lung decrease. Remember, we're creating that negative pressure to let air flow into the lungs. So again, that diaphragm really kicks that whole process off, and is that major muscle that plays an extremely important part in how we breathe. Exhalation is the opposite. So once they finish that breath in, the muscles start to relax, rib cage starts to return to normal position, the diaphragm relaxes and goes up into that, starts returning to that normal dome shape. Thoracic volume decreases. We start getting that pressure increase in the lungs to exhale the air out, and the air is forced out. So again, I just want to start off our conversation today with just a brief high-level overview of some anatomy and physiology, really highlighting the importance of the diaphragm and how we breathe, especially when we have someone on a ventilator. It's going to be extremely important to really be aware of the diaphragm, and we'll talk about some ways to kind of monitor it and ensure that that patient might be ready for the weaning process. So let's go ahead and get into kind of what's the heart of our conversation today is what is VIDD? So I thought this statement by Dr. Gallagher really kind of hit the bullseye when we're kind of giving just a general overview of what VIDD is. Dr. Gallagher is an intensivist out of Toronto, and him and his colleagues have done a lot of really great research and have some really good clinical studies on the impact of mechanical ventilation on the diaphragm, on VIDD, and a lot of the research that's been done on myotrauma, which we'll talk about here shortly. But Dr. Gallagher said the development of VIDD often constitutes a vicious cycle in which mechanical ventilation leads to diaphragm weakness that in turn perpetuates dependence on mechanical ventilation, leading to further diaphragm weakness. So basically what Dr. Gallagher is saying is that we place someone on a ventilator, we're controlling their ventilation, the diaphragm starts to weaken, therefore it really creates more dependence on the ventilator because we can't get that patient weaned off. As we know, the longer someone's on the ventilator, the weaker the diaphragm can get, the more potential for ventilator-associated harms can occur. So again, you have that kind of perpetual cycle that's going on. And we'll talk a little bit more about the vicious cycle, if you will, a little bit later in the presentation. But again, I thought this really summed up what VIDD is very well in this statement. All right, next we're going to take a look at some, I guess, historical perspective on some of the clinical studies that have looked at the impact of ventilation on the diaphragm. And we go back all the way to 1988. And this is a study done by Dr. Kinsley, Leal, and Singer. And what they looked at, or what they theorized, is that prolonged mechanical ventilation would have an impact on the diaphragms of neonate and infants. Unfortunately, with this study, it didn't really prove or have any statistical valid data that came out of the study. But what I think we do see is that they pose a really important clinical question for their studies. And I think this clinical question really influenced and really provided opportunity for future studies that we'll talk about in a moment to really examine that impact of mechanical ventilation on the diaphragm. So really the next study that we looked at that had some good data come out of it was out of 1994. And this was really the first landmark study that showed the impact of mechanical ventilation on the diaphragm. It was a study that looked at the diaphragm of rats and the impact of ventilation on their diaphragm. And what the data showed is that roughly after 48 hours of fully controlled ventilation, there was a large decrease in diaphragm mass and diaphragm contractility force. So not only did the diaphragm atrophy, but it was not strong enough or as strong as it was at baseline to produce the force to be able to spontaneously breathe or maintain spontaneous breaths. So again, a good study that showed there is some impact on the diaphragm from ventilation. Now, over the next 10 years or so, we do see some more clinical studies come out, but really the next big milestone in clinical studies was in 2008. And that was the first study that showed that prolonged mechanical ventilation can have a rapid impact on the human diaphragm and really create a very rapid diaphragmatic atrophy. So, something that we've seen, and now we have that clinical data to kind of validate that this does really occur, and this is something that we need to be aware of. So again, a lot of good clinical studies, and since that study in 2008, we've seen a lot more really good clinical data and clinical studies come out on this particular topic. So it's been around for a long time, and it's produced a lot of good data that supports the impact of ventilation on the diaphragm itself. So when we talk about VID, you kind of posed the question a few slides ago of exactly what is VIDD? So it's a form of iatrogenic injury from the mechanical ventilator. There also can be some pre-existing factors that contribute to the development of VIDD. We'll talk about those shortly: myotrauma, sepsis, malnutrition. And looking at some of the research, it reveals that within 18 to 24 hours of placing someone on the ventilator, they can develop VIDD. So this can happen pretty quickly. And thinking back to when I was a bedside RT, how many patients that I had on the ventilator greater than 24 hours, there was a lot of patients. So there's a lot of potential for the development of VIDD, um, diaphragmatic atrophy, and so many other injurious processes to the diaphragm itself. Now we're talking about how quickly it is. I want to touch base and just talk about how many patients are on ventilators, just to kind of give some context there. And roughly 15 million patients worldwide are annually placed on the ventilator, and approximately 30% or 4.5 million of those patients required prolonged weaning. So as you see, VIDD happens very quickly, and there's a lot of patients on the ventilator that require that prolonged weaning, which could be directly associated with some kind of diaphragm dysfunction. So again, it can happen quickly and it can be very relevant. Some other good statistics is that VIDD has a twofold higher occurrence rate than ICU acquired weakness alone. And when I mentioned ICU acquired weakness, it's really that weakness in your ICU patients, your critically ill patients, that really has no plausible etiology. So we're talking about polyneuropathy, myopathy, or muscle atrophy. So those really weak patients that have been, potentially in ICU for a prolonged period of time or on the ventilator for a long time, develop that ICU weakness. And those patients, we have a twofold higher occurrence rate of VID than actually ICU acquired weakness alone. And of those patients with ICU acquired weakness, roughly 80% of them develop VIDD prior to entering the weaning process. So again, a very high rate that this could potentially happen for patients. And approximately 60% of the patients that go into their first spontaneous breathing trial actually have severe diaphragm weakness. So again, we're seeing a pretty relevant number of patients that can develop VIDD and enter that weaning process of that first spontaneous breathing trial with some kind or some form of diaphragm weakness. And considering that 40% of the duration of ventilation is dedicated to the weaning process, this can be very challenging to have that patient prepared for the weaning process if we're not aware and we're not trying to mitigate some kind of diaphragmatic atrophy, diaphragm weakness, or VIDD in general. Okay, so we just kind of talked a little bit about some of the statistics when we're talking about VIDD, how relevant it can be and how quickly it can happen. One of the big contributing factors to VIDD is something called myotrauma. And that's really just a diaphragm muscle injury that can result or lead to ventilator-induced diaphragm dysfunction. And again, a lot of this research was from clinical studies by Dr. Gallagher and colleagues. And if we look kind of that flow chart on the right there, we see mechanical ventilation up at the top. Right below that, we see the 4 forms of myotrauma. So we have ventilator overassistance or excessive support, PEEP, which is your end expiratory shortening myotrauma, patient ventilator asynchrony, which is their eccentric contractions, and insufficient support, which would be ventilator under assistance. So as we follow that down, we see it really kind of leads to 2 different injurious processes, right? We have diaphragm atrophy and diaphragm injury, which are going to lead to a diaphragm muscle weakness and likely VIDD. So we can see there's a lot of potential opportunity to develop a VIDD, and really thinking about the 4 forms of myotrauma, which we'll talk about in just a moment. There's a lot of different kind of pathways that can take to that muscle or diaphragm weakness. So we're going to go ahead and talk about the forms in a little bit more detail. The first one, ventilator over assistance. This is the most common. Roughly 50% of patients that have myotrauma develop this type of myotrauma. So this is where we're over supporting the patient. Think of those patients that you placed on the ventilator that we are completely controlling their ventilation. The diaphragm is not active at all. And what can happen is that can atrophy very, very quickly. And, in developing a really clinically significant diaphragm weakness. I can recall many times when we were trying to get a patient ready for weaning and giving them different spontaneous breathing trials and trying to wean them down. And it just seemed like the diaphragm was not strong enough to maintain their own spontaneous respirations on the ventilator. So these are those type of patients that we're just over controlling their ventilation and not having some kind of diaphragmatic activity going on that again leads to that rapid diffuse atrophy. Next is ventilator under assistance. So think of those patients that we have on the ventilator that is working too hard. So we're not unloading those respiratory muscles. We're not managing their work of breathing very well because they're breathing really, really hard. And again, like any other muscle, if you work the diaphragm really hard, it's going to start thickening a little bit. It's not going to be functioning as appropriately or as it should. So those patients are going to be potentially getting some diaphragmatic injury from working so hard there. And it can also develop things such as pendulouf, where we're getting different inspiratory and expiratory going on in the different sections of the lung there. And it's not getting a good distribution of ventilation throughout the lungs as well too. So again, can definitely lead to some injurious processes and affect diaphragm and its ability to contract and its function as well too. Next is eccentric myotrauma. So really what eccentric myotrauma is those patients that are asynchronous or dysynchronous with the ventilator. So think about those patients that are maybe trying to exhale when the ventilator is trying to give a breath. We see ineffective trigger with this type of myotrauma, reverse triggering. So really those very abrupt and strong forces in the lungs there that are doing the fighting against the ventilator can really lead to immediate and marked diaphragm weakness. It's probably the most injurious of the forms of myotrauma because again we're kind of fighting against the ventilator there, so it can provide a very injurious process to the diaphragm itself. Typically occurs in the expiratory phase. Like I said, you think of those patients that are trying to exhale on the ventilator and the vent's trying to give that next breath, and those forces can definitely cause a lot of injury to the diaphragm itself. And the last form of myotrauma is expiratory myotrauma. Now, this form has not been clinically validated yet through clinical studies. It's just been theorized, I believe, by Dr. Gallier and his colleagues that really felt that having high levels of PEEP and then titrating that too quickly can take the diaphragm from a extended or elongated period of time there, or length, I should say, and really put it at a disadvantageous length. Again, there needs to be more clinical studies done on this, more validation through clinical studies as well too, but I felt important to at least mention in our conversation today, because as we'll see a little bit later, a couple of the clinical studies mention PEEP titration as an important part of diaphragm protective strategies. So thinking that along those lines of optimizing PEEP and really weaning it appropriately. Um, that's why I really wanted to mention this one, even though it's not been completely clinically validated yet. I think there's good thought process behind the management of PEEP as well too. So these are really the four forms of myotrauma. It really is a big contributing factor to the development of VIDD. I think when we're all kind of thinking about patients that we manage on the ventilator, we can kind of think of some of those patients that we've had that really might fit one of these forms of myotrauma, and understanding this and bringing awareness to it will really help, I believe, those conversations when we do rounds as to, yep, we're using lung protective ventilation, but is there more we can do to maybe protect the diaphragm as well too? Because we know that you protect the diaphragm, you have that ready, have some diaphragm activity, we're going to enter that weaning process in a much better place than we would if we did not. So again, the different forms of myotrauma are important to kind of be aware of and understand what each of them is. So next, we're going to go into some of the diagnostic tools or tools that can be used to um, evaluate the diaphragm, kind of continue to monitor that diaphragm, because again, that's going to be a very important piece. And a lot of these, as we know, you want to kind of get that baseline view of the diaphragm to understand any changes that are made during their time on the ventilator. So one of the first tools that's been used for a number of years here, kind of the gold standard, is the phrenic nerve conduction, looking at quantifying the function of the diaphragm there. There are some drawbacks to it. Requires a lot of patient effort, expertise, requires some specialized equipment, and can be a bit expensive and time consuming. So think of those really critically ill patients that you would have to take from the ICU, transport them down to wherever they do this testing. And that's not always an option, right? We'll have those patients that are way too sick to go anywhere to CT or really any kind of testing. Plus the time and the effort it requires from the patient and the staff, not necessarily the best option these days. And we'll talk about a few better options here shortly. Next one that you could look at to assess diaphragm function would be fluoroscopy, which has some limiting factors as well. The patient could be exposed to ionizing radiation. Again, very similar thing with the phrenic nerve conduction. It's you have to transport the patient to probably your X-ray department at that time. There's a cost associated with it that is higher than some of the other options we'll look at here shortly. So fluoroscopy may not be the best option as well too, especially when you have that critically ill patient that is not quite at that point where they could be taken out of the ICU for some testing. So those are two kind of more traditional methods to look at diaphragm function. The next one we're going to talk about is really gaining a lot of traction when we're looking at ultrasound, the diaphragm, and that would be ultrasound. So we know the ultrasound is very quick. You can have reproducible results. You don't need to transport the patient. It can be done right at the bedside, and it's a very safe method to evaluate the diaphragm. And some of the studies that I've looked at when I was developing this presentation there were really focused on showing the use of ultrasound and evaluating the diaphragm. So some really good clinical data came out of this topic as well too. So when you're using the ultrasound to evaluate the diaphragm, it really does a couple things. It looks at the diaphragm excursion and the diaphragm thickening fracturing. Most of the time they're going to evaluate the right hemidiaphragm. There's really two modes that can be used for the diaphragm or the ultrasound, your B mode or 2D mode or M mode. M mode is the typical one that's, from what the research says, typically used for evaluating diaphragm excursion and thickening fraction, and has been very good to, again, for reproducible results and to really evaluate that diaphragm to see if potentially that patient is ready for weaning or if some other interventions may need to be done. So I mentioned diaphragm thickening fraction, and what that really is looking at is the diaphragm, the functionality, the strength of the diaphragm, and the excursion of it there. And we know that 30% roughly, and anyway, actually, you can go anywhere from 20 to 30% of patients will say um, encounter some kind of difficulty weaning or some issues with the weaning process. And this diaphragm thickening fraction and diaphragm excursion through the ultrasound can really help kind of look at and identify those patients that either might be ready, that their diaphragm looks good, it's pretty close to baseline, or we're seeing some issues where we're seeing some diaphragmatic atrophy or some functional impairment due to maybe some injurious processes that are going on. Um, so again, it's a very easy tool to use. I feel an important tool that we could have in our arsenal to evaluate the diaphragm and see where we're at baseline, see where we're at when we're feeling that we're ready for that weaning process, and determine if that patient is going to be ready. Some of the studies also show that roughly when you have a diaphragm thickening fraction of roughly 30 to 36%, that's a good predictor for weaning success. So there are, some few studies out there with some kind of guidelines to give you some ideas of where your thickening fraction should be, and um, you know, kind of statistically how successful weaning may be when we're in that kind of range there. So some good tools to evaluate. I think the ultrasound is an excellent way to assess the diaphragm because it could be done in bedside. It's safe for the patient. It can be done fairly quickly, and if we get that baseline, we can see if that patient is ready for weaning depending on what the diaphragm ultrasound shows. All right, next, we're going to get into a little bit of the contributing factors or additional risk factors to develop VIDD. Patients may not develop VIDD directly from these two, but they definitely can play a big part in the development and have a lot of impact on the diaphragm because it is muscle. So what I'm talking about up at the top right, you see the two in red there, sepsis and malnutrition. So two things that we see in the hospital, and they both can have contribute to the development of VIDD. As we kind of follow that path along, we see that sepsis can develop into some oxidative stress. You have some protein degradation, and we know that can really impact muscle and develop muscle atrophy if that occurs. But both of those, malnutrition and sepsis, both lead to loss of mass, which leads to diaphragm atrophy. So as we can see that they both can have an impact on the diaphragm and really contribute to VIDD. And we'll get into a little bit more detail here in just the next slide. So first we'll kick it off with sepsis. So like I mentioned previously, sepsis can cause some oxidative stress, which may increase the generation of some inflammatory cytokines, but it also can reduce protein synthesis and increase proteolysis. So we're seeing that protein degradation. We're seeing that this can impact diaphragm muscle and create some diaphragm muscle atrophy and some contractile dysfunction as well too, which would lead to diaphragm VIDD, diaphragm dysfunction. So again, all those patients that we've seen with that become sepsis, that potentially get intubated, when we're kind of formulating or developing our strategy and how to take care of the patient and ventilate the patient, just be aware of the impact this can have on the diaphragm as well too. Because like I said many times, if the diaphragm isn't prepared for the weaning process, it's going to be on the ventilator longer and just lead to kind of snowball into a lot of other things potentially. So I think healthcare in general has really improved and done a great job over the years at identifying sepsis and treating sepsis. But again, I just wanted everyone to be aware of the potential impact this could have on the diaphragm as well. The same kind of goes for our topic on nutrition. We know that, again, protein metabolism is very sensitive to the nutritional states. any kind of nutritional deprivation, short-term, long-term, can really result in significant loss of diaphragm muscle. So think of really any muscle that if it's not getting the proper protein and the proper nutrition, those muscles can weaken, they can atrophy, and the diaphragm is no different. It's still a muscle. So when that weakens, you're developing some ventilatory failure potentially on the vent a little longer. Very similar to sepsis, where it's creating some diaphragm muscle atrophy and contractile dysfunction because that muscle is not strong enough due to the nutritional state of the patient. So again, it can have a very big impact. It's not, potentially not associated with impact of the diaphragm. Again, just bringing more awareness that malnutrition can have and be that contributing factor to, that path to VIDD as well. All right. And if you recall earlier in the discussion, I mentioned that vicious cycle that Dr. Galler kind of articulated in his statement there. When we look at the slide here, this is kind of that vicious cycle that he was kind of alluding to. So when we place someone on the ventilator, we're controlling their ventilation, and then, if we're not monitoring it, that patient can develop some diaphragm weakness, some form of myotrauma, depending on what's going on with the ventilator. Developing that myotrauma kind of starts that path to VIDD that could lead to difficulty weaning. So we have difficulty weaning because that diaphragm is not prepared for the weaning process. Maybe we get to and fail like one of our first SBTs. We're on the ventilator longer, so we have increased ventilator days. We know a few things. Increased ventilator days lead to increased costs. So increased nosocomial or hospital-acquired infections, additional ICU days, additional testing, our morning blood gases and chest x-rays. Maybe the patient needs to go for a CT. So we're seeing that increased cost as well too, which can impact not only the patient, but the hospital as well too. Longer days on the ventilator can lead to increased or poor outcomes. So we may see increased mortality. We may see, instead of being able to extubate that patient, now we have to trach the patient. So they're on the ventilator longer. We have a procedure, the tracheostomy. So there's a whole host of things that can occur the longer the patient's on the ventilator. There's a lot of different ventilator-associated harms, villi and anaphylactic trauma and barotrauma that can occur. So, we definitely want to get the patient off as quickly as possible. But when we start getting into this cycle that we see, that doesn't necessarily always happen. And, we start leading down that path and we hit the poor outcomes. The patient's on the ventilator longer, and then we kind of start that cycle over again where we're still on the vent, diaphragm weakens some more, still having difficulty weaning. So we see this this vicious cycle occur over and over again. And again, bringing awareness to how mechanical ventilation and other factors impact the diaphragm, I think is important, because that brings more awareness and it brings better discussions or conversations while we're doing rounds and developing our strategies to manage those patients on the ventilator. So when we talk about those patients on the ventilator, we have to talk about how to mitigate this diaphragm dysfunction, how to mitigate some of the myotrauma as well too. So a few things that I think really need to be highlighted when we're talking about strategies to mitigate VIDD is, one is to engage the diaphragm. So have some kind of level of diaphragm activity going on so they can maintain some spontaneous breathing so that they are more prepared for that weaning process. Two is another really big part of it is optimize patient ventilator synchrony. We know those patients and we've seen those patients that are not synchronous with the vent. We have prolonged ventilation. We have a lot of challenges to, hopefully mitigate any kind of injurious process, keep those, different lung pressures lower, minimize those as well too. And it's very challenging when the patient is not synchronized with the vent. And one of the third really big key to it is managing patient sedation. I think, again, healthcare as a whole, I think is doing a much better job at managing sedation than we did 20, 30 years ago. We understand the impacts of it, especially with our patients on the ventilator. And we'll kind of go walk through a study here in a few moments that really kind of highlights that, that point is in managing patient sedation. But first, we're going to start off with a study from Dr. Shepins and colleagues from 2019, and they really looked to identify some targets for diaphragm protective ventilation. Now, when they mention diaphragm protective ventilation, I think this could absolutely be used in conjunction with lung protective ventilation, because we're still going to use those smaller tidal volumes. We're still going to try to minimize those driving pressures, the plateau pressure, but I think aspects of the diaphragm protective ventilation could be brought in as well too. And what Dr. Shepins and colleagues found from their research was that you really need to preserve a low to normal amount of diaphragm activity. So engage the diaphragm, get that diaphragm working a little bit. They're not saying have it do all the work, but have just do enough to keep that diaphragm working, uh, prevent it from atrophying it, and that'll be much better when we get to that weaning stage. 2, avoid dysynchrony. So again, the importance of patient ventilator synchrony plays a huge part in mitigating diaphragm atrophy, mitigating injurious process to the diaphragm as well. And here's where we see the PEEP titration come in. And I mentioned that expiratory myotrauma. They felt that PEEP titration was important as well too, to optimize the PEEP and not necessarily go from a really high PEEP down to a lower PEEP in an inefficient manner. So when we look at this image here from their study, see up at top, we have inappropriately titrated ventilation, and then below that are the different forms of myotrauma. As we've seen before, they all kind of lead to one or two things. We either have an injurious process or an diaphragm atrophy. And at the bottom there, we see their targets for ventilation or diaphragm protective ventilation. Avoid dysynchrony, preserve a low to normal amount of diaphragm activity, and optimize PEEP are going to be the important kind of approaches, from their perspective to kind of protect that diaphragm during ventilation. And I also mentioned sedation was a big piece too, and we had a study come out this year from Dr. Sklar and colleagues, and they looked at really the time from intubation to the time that they can see a diaphragmatic signal in the patient. And they use something called EDI catheter, which is a part of the servo ventilator and the NAVA technology. And what they kind of theorize is that disease severity and sedation had a major impact when we saw the diaphragm activity return after intubation. And what the results showed was that really continuous sedation had the biggest or most impact on the resumption of diaphragm activity. And they looked at it roughly, they wanted to hit a baseline of 7 millivolts on the EDI monitoring waveforms to consider that a resumption of diaphragm activity. And of those sedatives they use, propofol-based sedation had the most profound impact on diaphragm activity. So again, we're seeing those sedatives that really is going to blunt the ability for the diaphragm to receive those signals and kind of blunt the ability of the diaphragm to react and start breathing and going through that process that they do. And of the patients in the study, roughly 50% did not recover their diaphragm activity within 1 day. So that first day that they're on the ventilator, really no diaphragm activity. It wasn't until the second day that they started seeing much more of the patients within the study get that diaphragm activity back. And there was actually a few, I believe 5 out of the number of participants that after 5 days still did not have any diaphragm activity at all. So again, sedatives are the main factor. Their other part of their theory that illness or lung severity played a part. That really, there was no statistical significant data that showed that the disease or illness severity really impacted the resumption of diaphragm activity. So really the key takeaway from this study was, manage sedation, really look at the uses of continuous sedation, boluses, because that can impact the diaphragm, resumption of diaphragm activity. And we know that when that happens, we're on the ventilator longer, we have prolonged weaning as well too. So we can even see it in the image to the right there where the black line is really no sedative use. We see that probability of resumption much higher in a much quicker time frame. And with the blue line is the use of sedatives. So it's a much kind of prolonged return for the diaphragm activity in these patients in the study. All right, next we have a study that was done by Dr. Eddie Fan and colleagues. They looked at the ARDS and some of the advances in diagnosis and treatment. They identified myotrauma as one of the biggest factors that they saw when they did their meta-analysis. And what they theorized is that you really should be looking at diaphragm protective strategies, kind of what we've been talking about a little bit too. In addition, patient ventilator dysynchrony, again, another thing we've mentioned, and how to kind of help mitigate VIDD. And what they said here is look at different forms of ventilation, such as NAVA or PAV. There's kind of assisted ventilatory modes there to really help the patients to mitigate dysynchrony as well too. So monitoring is another big piece of helping to mitigate VIDD. And one of the key pieces that you can utilize is, again, I mentioned before, the EDI or electric activity of the diaphragm. It's a catheter that goes in and hooks up to the ventilator. It's going to monitor the diaphragm activity. It's going to allow you to see some asynchrony to make sure that the diaphragm's signal is strong. So you'll be able to kind of monitor that patient through the whole process to make sure that they've got their diaphragm activity back, that it's strong enough to maintain some spontaneous respirations, and that it is synchronized. So the patient gets what they, helps synchronize the ventilation with what the patient wants and needs. The other piece we mentioned in monitoring is the use of the ultrasound to look at diaphragm excursion and thickening fraction. Again, that's going to be important to monitor to see baseline and to see if there's been any changes in the diaphragm of the ventilated patient. Talk about the ventilator itself and mode. I mentioned NAVA, and really this is a assisted mode that delivers ventilation in proportion to and in synchrony with the patient's EDI signal. So you're going to have higher diaphragmatic efficiency and fewer periods of over or under assist for that patient, and also promotes lung spontaneous breathing. So we're seeing patients that are more in sync with the vent, which is important, and we're decreasing the potential to develop those diaphragm injuries, diaphragm atrophy, and VIDD as well too. Speaking of NAVA as well, we looked at a study from 2009 from Dr. DeWitt and colleagues that said roughly 1 out of 4 intubated patients suffers from severe asynchrony, resulting in longer stay, increased ventilator days. And then we had a study from 2020 come out by Dr. Kazmierik and colleagues, the Navigator study, and that really showed the use of NAVA can decrease the duration of ventilation, increase ventilator-free days. So as we get better patient ventilator synchrony, the patient is engaging that diaphragm, and if the sedation is managed appropriately, we can see these patients get off a little sooner, and we know that can help mitigate the potential for VIDD. Okay, so sorry about the dog, guys. Just to summarize, VIDD can happen very quickly, roughly 18 to 24 hours after mechanical ventilation is initiated. And there's strong clinical data that supports the prevalence of diaphragm weakness in our patients. Kind of remember that 40, 60, 80 rule we talked about earlier. 40% of the time is dedicated to weaning process. 60% of patients enter the first SBT with severe diaphragm weakness. And 80% of the patients as well develop diaphragm weakness when entering the weaning phase of ventilation. We also talked about the 4 forms of myotrauma: overassistance or excessive support, insufficient support or ventilator or under assistance, our eccentric contractions. Was that patient ventilator asynchrony or dysynchrony, and the one that has been clinically proven yet is the unoptimized PEEP or the unexpiratory shortening. We talked about some additional risk factors for VIDD as well, sepsis and malnutrition. And then we looked at some strategies to help mitigate VID. So monitor and engage the diaphragm was really important. Optimize patient ventilator synchrony. I get another big piece of that. And then finally, manage PEEP and sedation. So I think when we look at these different strategies, it's really all about being aware of what can impact the diaphragm, understanding that the diaphragm really needs to be in that place where it's ready for weaning, because we've seen many times and many patients that enter the weaning phase and we have prolonged weaning. So we really got to have those patients prepared to enter that weaning phase of ventilation. And a lot of these things that we talked about today will help, again, bring awareness, kind of kick off those conversations while we're doing rounds, and ensure that we're developing strategies that are going to help that patient not only improve their health, but improve the diaphragm and be prepared for that weaning phase. So again, thank you guys for joining us today. I hope you guys found this topic interesting. I always enjoy talking about it, and we'll open it up to some questions now.
Thanks, Bill.
Yeah.
If anybody has any questions for Bill, please go ahead, and if you want to verbally ask him, go ahead and unmute yourselves and ask the question, or you can put it into the chat box and I can ask Bill. Bill, I had a question. I know that comes as a surprise to you.
Absolutely.
With the more common use of APRV or bivent, has there been a decrease in VIDD?
Good question. I don't think they've really identified one particular mode that says if we're using APRV, bivent, NAVA, PAV, whatever that mode will be, is that we're seeing a decrease in the occurrences of VIDD. At least nothing that I've seen in any studies that have any statistical validity to it. I think the main piece to take away from it is just, again, like the other study said, having some kind of low to normal diaphragm activity, regardless of the mode used. I think a lot of it's going to depend on the practice at each facility. Not every facility is using APRV, NAVA, PAV, whatever that may be. So whatever you guys have in your protocols at your facilities, just to make sure that we are engaging that diaphragm a bit, trying to have some low level of spontaneous breathing going on, I think is really the more important theme, as opposed to like a specific mode. So it's going to be, some of it's going to be clinician comfort as well too with the different modes, but yeah, I think the more important piece is just you have some kind of minimal diaphragm activity going on.
Well, thank you, Bill. We really appreciate you coming today and presenting for us. Thank you again. It was great.
Yeah, absolutely. Thank you guys. Again, happy Respiratory Care Week next week, and have a great weekend, everybody.
Thanks, Bill. Great
Thanks,
presentation.
Bill.
Thank you much.